Hello, and welcome to today's episode of Health University, where I have the pleasure of speaking today and sharing with you the knowledge of Dr. Cassie Hyde. Dr. Cassie is a doctor of physical therapy with a specialty in pelvic floor physical therapy. She attended the UCSF San Francisco State University Doctor of Physical Therapy program and has significant experience with outpatient services and sports-related injuries. And for the sake of this conversation, we're going to focus on her training with the Herman and Wallace Institute that expanded her knowledge in pelvic floor physical therapy. So welcome, Dr. Cassie. It's a delight to have you.
Thank you, Susan. I'm really happy to be here.
Is there anything that I missed in introducing you that you want to make sure that you've covered?
No, that's it. I
Okay.
was happy to come back to San Francisco to do my doctorate training. And
Mm-hmm.
then, yeah, I've expanded with Herman Wallace and I've been
Mm-hmm.
doing pelvic health focused physical therapy for about 2 years now.
Excellent, excellent. And Dr. Cassie works in the San Francisco Bay Area in Marin, in Mill Valley, just down the road from me. So if you're listening from the North Bay or the San Francisco Bay Area, be sure to check out show notes and schedule an appointment if any of this conversation piques your interest or raises a red flag, so that we want to make sure your pelvic health is attended to in preparation for and during and delivery and postpartum.
Yes.
So, without further ado, I'll begin just with a few kind of questions because pelvic floor physical therapy is its own domain, if you will, of physical therapy. How would you describe pelvic floor PT, and what do you treat in pelvic floor PT?
Absolutely. So I like to approach all issues from like a broader scope. So I start by assessing your whole body. How your pelvis comes into play with things is kind of the secondary part that we have that special training for.
Mm-hmm.
The main kind of things I treat are urinary dysfunction,
Mm-hmm.
pelvic pain, pregnant and postpartum dysfunctions, and just kind of training and some kind of like bowel sided things as well.
Gotcha. And when you say training, I'm air quoting this, is that to say you're helping a person sort of recognize and identify the inner parts of her body so that she can actually feel, and forgive me, I'm using the personal pronoun she just for the sake of not tripping over my tongue, but so that she can feel if something's gone awry before she gets to the place where she's, kind of struggling to get out of bed or the car or to walk.
Absolutely, yes.
Okay.
As well as like push training and labor education, get
Mm.
into things as far as like breastfeeding and how
Mhm.
our ergonomics come into play there,
Mhm.
lifting babies, all this stuff. So I run the gamut from the beginning
Gotcha.
all the way through the end.
That is great. I have a question that just kind of popped into my mind. Is there a pattern or a trauma or something like that that you notice when a woman is struggling with fertility? And I don't call it infertility, I call it subfertility, because I personally believe a small population of people really are infertile. Delighted for the diagnosis because it gets more people help, but I think the diagnosis itself can put someone on their heels thinking, not fertile. But I have this idea that sexual trauma, perhaps sports related injuries as a teen or even a younger person could all play a part in what creates a pelvic floor dysfunction that then is possibly part of a subfertility issue. Do you see any patterns like that?
Absolutely, yes.
Yeah.
Typically, the people that come to me who are struggling with their fertility are people who struggle with painful intercourse or high
Hmm.
tone pelvic floor. So that's an inability to kind of let go of some of that tension. That's just like the muscle memory of those muscles wanting to stay hyper contracted. And we have to kind of work on educating that release. And that
Hmm.
goes very hand in hand with sexual trauma. It goes hand in hand with just like habit forming. So all of these things come into play. And those are typically the types of patients that I see in my office who come to me with like, I want to be able to tolerate intercourse regularly
Yeah.
in order to get pregnant.
Yeah.
Yeah.
Yeah. And just to have a relationship and enjoy that intimacy. And
Yes.
and I heard, and I want to, I'm going to pin this for the listening audience. I heard you say pelvic tone, and we think of tone as being a good thing, but tone is tonic. It's tight. It's contracted. So how might a person recognize that she has pelvic tone issues? Like what might be some symptoms outside of painful intercourse?
Often, I will say this loosely, but often a person before they have had children, if you are struggling with stress urinary incontinence, so leaking with coughing, sneezing, laughing, jumping, if those type of things are creating urinary and you have not had any children recently, I'll say,
Mhm.
that is another sign of a high pelvic, like high tone in the pelvic floor muscles, because those
Mhm.
muscles don't have that flexibility and give to kind of adjust to that increase in pressure in your abdomen.
Mhm. Okay. All right. Okay. And then if someone is trying to get pregnant, what symptoms might be a red flag for her, again, aside from, painful intercourse, to say, maybe something's going on here. And I'm thinking perhaps like, ovulatory pain, middle smirts,
Mhm.
or painful menstruation or
Yes.
or PMS symptoms. What do you see and recommend that someone take a look at and come see a pelvic floor PT should she find herself, struggling with any of these?
Yeah, absolutely. I mean, constipation is another one, but
Mm,
also like extremely painful periods. So
mhm,
if you've ever had the word like endometriosis thrown around with your care and stuff like that, we do a lot of work not only on recognizing pelvic tone, but as well as reducing some of those endometrial flare ups.
Well, I'm really glad you mentioned it because that was going to be my next question about endometriosis in particular, because it is pelvic floor pain that someone experiences either at ovulation when hormones are at their highest, or just before menstruation when the endometrial tissue is being given the signal to shed, and that endometriosis is trying to shed inside the pelvic bowl, but doesn't have the exit, if you will, through the vagina. So what would you recommend and what do you do? Are you able to, with manipulations, break some of those adhesions and help that endometrioma or endometriosis kind of dissolve a little bit?
Yes, absolutely. We do
Wow.
a lot of hands-on therapy as well
Hmm.
as working with our myofascial decompression. So
Hmm.
cupping, basically. We have just soft silicone cups that I
Hmm.
use on like abdomen, low back, all
Hmm.
those kinds of areas. So there's lots that we can do externally as well as internally. Sometimes that's less tolerable during a endometriosis flare up.
Hmm.
And so there's a lot we can do working on the abdominal wall and the abdominal fascia, where some
Hmm.
of those endometrial adhesions can develop
And of course, they can develop in anywhere, right?
anywhere.
They can be on the rectum, the bowel, the ovary. Goodness, they've seen that endometrial tissue float all the way up to the nose, and someone
The
gets
eyes, yeah, I've read
gets
that.
bloody noses every time they're having their period. That's very interesting. And of course, cupping, being a doctor of Chinese medicine and
Yeah.
acupuncture, cupping is a favorite of mine as well. So I'm all for the cupping. We wear those cupping bruises proudly should you get yourself some cupping.
And I love that because cupping is a great tool that like I can educate my patients to use on themselves. Like you can
Mhm,
buy these bags of silicone cups for $20 on Amazon, and then if there's
mhm,
something that are really helpful for you, we know
mhm.
that endometriosis is not one of those kind of one and done treatment plans.
Right.
And so that creates a tool that my patients can actually utilize at home.
Right, that's excellent. Do you, I'm getting in the weeds here, so forgive me, listeners. Do
Mhm.
you have them move the cups or just apply them and have them hold in a particular location where the
Both,
pain? Both.
both, and
Hmm.
whatever's tolerable. I've also done just like twisting in a circle and not
Hmm.
necessarily moving along the tissue.
Hmm.
Like when my typical protocol would be to place, make sure it feels okay, and then start gliding along the
Yeah,
skin
that's
and
mine as well.
help with the fascial mobility. Yeah.
That's mine as well. And then would you find that gua sha, that scraping tool, to be useful, or does it not go deep enough?
That I feel like would be more useful if someone's even more sensitive. Like if
Okay.
the cupping is too intense, then we can just do. I've also done like skin rolling,
Hmm.
or just like hands-on compression techniques. I don't
Hmm.
typically use gua sha, but yeah.
Okay. All right. I want to make sure the conversation is about fertility, but of course, everyone who's talking about fertility wants to become pregnant. So let's just presume that good fortune has occurred and someone is pregnant. Are there pelvic floor PT red flags? I'm being a little redundant here. In the first trimester, in the second trimester, in the third trimester, and postpartum that you would like to speak to?
Absolutely,
Okay,
yes.
let's go.
I usually say that there are three groupings of symptoms that would kind of raise a red flag that, oh, maybe I should talk to my gynecologist or my OB and get a referral for pelvic floor physical therapy. The first one is urinary, so an increase in urgency, which a lot of people talk about with pregnancy. Even
Hmm.
as early as the first trimester, people are like, why am I peeing all the time? Why am I getting up 3 times at night to pee?
Hmm.
All of this kind of frequency stuff, as well as I mentioned earlier, stress urinary incontinence
Hmm.
with like coughing, sneezing, etc. So
Hmm.
either of those two things, urinary leaking during the day, as well as an increase in urgency at night, more than
Hmm.
like getting up once a night, I would say
Hmm.
would be the max, would be a red flag or something that should trigger you to go to pelvic PT.
Hmm.
The other two groupings is anterior pelvic pain. So anything in the front part of your
Hmm.
lower abdomen.
Hmm.
That includes like pubic symphysis pain,
Absolutely. Hmm.
round ligament pain,
Hmm.
as well as just like pelvic floor pain, like pain around your vulva.
Hmm.
And then posterior pelvic floor or pelvic
Hmm.
pain. So that's like
Hmm.
your low back, SI
Hmm.
joint, piriformis symptoms, like sciatica, all of
Hmm.
those things. So those are
Hmm.
kind of your groupings that
And
I would.
I imagine you find people almost sequentially, they be if they're going to begin with, urinary incontinence, then they probably are going to progress to these other symptoms because it's the same location that is having advanced or amplified pressure from a growing baby,
Yes.
as well as the relaxin hormone that is doing its job to relax the joints, the whole body, but especially the joints. And so pubic symphysis pain can become really prevalent. So don't wait. don't
Yeah.
suffer through the inconvenience, because it can feel sometimes like, oh, it's just inconvenient that I need to get up 3 times a night. Really let that be a sign that there's something to be cautious of in your future pregnancy and postpartum. So address it now so that you don't have to go down that path.
Yes,
Hmm.
absolutely. And it's just so like normalized, I think. And I'm here to kind of be like, nope, not normal. It doesn't have to be
Hmm.
normal. We should not
Hmm.
be peeing more than 8 times a day. You should not have urgency with your urges to void. Yeah, and
Hmm.
you should not be going more than once, maybe. And that's only if you're pregnant.
Okay, very good. And then what about delivery and postpartum? Are there things that someone should be paying attention to in her early pregnancy with her pelvic health so that there aren't tears and so forth? And I know, birthing, labor, and delivery is its own life event where we can do the best we can and things can happen, but maybe there are things we can do to mitigate or minimize the likelihood of these things.
Yes. Well,
Okay.
I love getting to people early, right? So
Hmm.
anybody who's come to see me for any type of dysfunction while they're pregnant, I do a full course of labor positioning education as well
Hmm.
as push training. Usually into the third trimester is when I'm starting to kind of transition to
Hmm.
a lengthening plan regardless of what you had been seeing me for. We typically do a lot of strengthening at the beginning if because of the instability,
Hmm.
and then as we move into those last few weeks, we are focusing a lot on down training, relaxing the pelvic floor, hip mobility. And then I also do, as I said, all of this push training.
Hmm.
So just figuring out where your pelvic floor is can prevent a whole host of things that can complicate delivery itself.
So go ahead. I just, I'm thinking now, do you do video consultations? Because here again, we can be limited by our zip code for people who can get into the office physically. But if there's somebody in California, because I presume like myself, you're licensed and so therefore can't be practicing outside the state. But if someone's anywhere in California or wants to come in for a visit and then go home, because then person can become a patient of record. But do you do video consultations where you can help a person, kind of identify what those exercises might be, or do you really just need to have hands-on in order to know that you're delivering the proper instruction?
I mean, it's definitely more effective with hands-on, but there's absolutely, I can perform all the education virtually via Zoom. They do have to be in the state of California for licensing reasons. Also, since COVID, insurances are kind of changing, which
Mm-hmm.
are still covering telehealth and which are not. But we
Mm.
absolutely could do a self-pay virtually. That there would be no problem with that.
Mm-hmm. Mm-hmm. And then you could just give a super bill and they could figure it out with their insurance company.
Yes.
Excellent, excellent. Okay, I want to make sure that I'm not missing anything because you were kind enough to share with me what we wanted to speak with, and then I kind of went on my own little tangent. So there is one question. It's like what, and you touched upon it, but I want to make sure that we didn't miss anything. The types of dysfunction symptoms. So we covered urinary stress incontinence. We covered painful intercourse. We covered discomfort around, ovulation and menstruation for endometriosis. Anything else that a person might say, "Oh, wow, I have that one. I didn't have these others, but I have that one."
Yeah, I think I just briefly mentioned it, but constipation is another
Mhm.
big one. And that can also be a symptom of a high tone pelvic floor.
Mhm.
We need to relax our pelvic floor to let anything in or out. And so
Mhm.
not
Mhm.
having that ability definitely contribute to constipation, bowel dysfunction, all that kind of stuff.
I see your boss. Mine is in the other room.
Cuddly dog.
Oh, lovely, lovely, lovely. Okay, so then what about postpartum? So
Yeah.
someone has gone through her, her pregnancy and delivery, and either it went as smoothly, and of course, delivery is a feat of courage and endurance like no marathon or triathlon could be. But what, even if under the best of circumstances, what do you find occurs so that it makes sense to visit with someone postpartum?
Absolutely. So, ideally, if I am seeing you before your delivery, I recommend a 4 week postpartum follow up and a
Mm-hmm.
6 week postpartum follow up, basically for everyone.
Mm-hmm.
We've seen that getting to people earlier is better, always
Mm-hmm.
better. We
Mm-hmm.
don't do any internal assessment or strength assessment until people are cleared by their OB at their 6 week post appointment. So that's why I kind of the 4 week one is a lot of discussion. We're talking how did everything go? How have the first 4 weeks been? Are your wrists like mommy wrists? Are they hurting? Is your
Mm-hmm.
upper back and neck bothering you? Any other kind of like orthopedic dysfunction that can occur postpartum in those early
Mm-hmm.
weeks. We
Mm-hmm.
also start very gentle abdominal strengthening, just like kind of bracing and activating, and pelvic
Mm-hmm.
floor activation.
Mm-hmm.
And then at that 6 week appointment, after you've seen your OB, if everything's cleared, we do a pelvic floor strength assessment. And from
Mm-hmm.
there, we basically hit the ground running with the goal of getting patients back to where they were before,
Mm-hmm.
what their goals are. If that's running, if they have a physical job,
Mm-hmm.
all of those kind of things are our goal postpartum.
Cool. Very cool. There was something that you had said, and it kind of came and went right through my mind. Oh, I know what it was. You talked about mommy wrists and neck pain from nursing and all of that. So I wanted to just highlight that for a second because we're talking pelvic floor, but we have a whole body. And so if you're having carpal tunnel or something like that, tell me, is it correct to presume that even if you're not feeling discomfort in other locations, perhaps that symptom alone warrants both a sort of a loose ligament assessment and treatment for the wrists themselves or the neck and shoulders themselves, but also pelvic floor?
Yeah, I mean, it's always important to clear someone
Mm-hmm.
for their pelvic floor strength after having a baby.
Mm-hmm.
We want to make sure that we're not getting into the back to impact activities before a professional or a doctor or someone tells you, yes, your pelvic floor is back to its normal strength. We're happy with this, because we're trying to prevent issues down the line.
Absolutely. I
Our
only
pelvic,
wish that back in the day we had this
yes.
kind of attention, because we, in my generation, we were trying to literally hit the ground running, within a few weeks with the baby jogger and getting out, and getting exercise, because that was supposed to then have been the best thing to do. And the consequences are real, if there's laxity in the pelvis and you're applying gravity and pressure. Well, guess what? That pelvic bowl has space in it that where all the organs have not found their way back and the muscles have not found their way back. So take the time. It's one of those things. If I knew then what I know now, it would have been a very different outcome for immediately postpartum, in my 40s, in my 50s, and so forth. I'm in my 60s, so I'll stop there.
Yes, and I know that this won't be released right away, but we are filming this the day after Mother's Day. So
Exactly.
happy Mother's Day to you
Thank you. Thank
and
you.
all
And
those
happy
moms.
Mother's Day to the mother in all of us. I actually did a podcast, because here again, talking fertility challenge, it's sometimes the most painful day of the year for some people. But I do
Yeah.
want to remind everyone, even today, that, mothering is not simply the act of being pregnant, delivering a child. We mother every day in our personal and intimate relationships, in our professional relationships, with our animals. Just the way we think it has a lot of mothering instinct to it. So I want to make sure that no one feels excluded from the term mother. I think that Hallmark did that to us. Marketing did that to us. So all right. Well, I want to be respectful of your time and then of the listeners' time. And I do want to make sure that if there's anything that we didn't cover, that you would say, oh, no, we really want to take a little deeper dive on this subject.
I think there's just one last little tidbit that I wanted to make sure that we cover, and that's basically, I think we forget that the pelvic floor is our core. It's the base of our core.
Mm-hmm.
It supports our trunk, which is our center, our core. And a weakness in the pelvic floor can cause a whole host of issues elsewhere, can cause other muscles to work too hard or not enough, or imbalances in general.
Mm-hmm.
And so we want to make sure that we're addressing the entire abdominal bowl, pelvic bowl, and that has a huge impact on how we live our lives, especially when it comes to walking, lifting, all of those things. And so,
Carrying a baby through toddlerhood while
yes.
trying to carry the diaper bag and your own purse and the keys and all of those things. Absolutely. And it's interesting. I'm grateful that you raised this, because I think, if I am an example, there is a tendency to think of the core as being the abdominals.
Mm-hmm.
We do our hundreds to strengthen our core, or we do our sit-ups or whatever, legs up and down to strengthen our core. But if we're only thinking of our abdominals, we're actually missing the engagement of these key hidden muscles that become, and ligaments that become problematic if they don't get engaged properly. That's where you say we've got, hypertonic rectus abdominis, but we've got, a kangaroo pooch from below our belly button, right? Yeah.
Absolutely, yes.
Excellent. Well, I can't thank you enough for your time this morning, and I want to make sure that the listeners know that the show notes will contain a way to connect with Dr. Cassie, and if there's any questions that they have, they can reach out to you. I presume is there a
Yeah.
contact form or something like that will be up through
Yeah.
your website? Okay, perfect. So, listeners, thank you for your time. Dr. Cassie, thank you for your time. And as we say at Health University, class dismissed.
All right. Thank you, Susan.